A really good morning to you. It's nice to see so many of you here. I'm Tracy Doucet, for those of you who I haven't met before. For those technical people in the audience, I make no apologies. I don't have a technical background. I'm an ex-NHS chair of a foundation trust, where I was for 5 years, prior to which I have a commercial background. So my expertise is innovation, innovation, financials and turnaround. But I'm hugely passionate about technology, in particular in relation to healthcare and its ability to transform. So I guess for my sins, I've done quite a lot of UK speaking and European speaking. And in February, we founded a business called Innov8, which I'll tell you a little bit about, to do just that, to support healthcare organisations to transform services, clinical pathways and efficiency through transforming technology, with a real important eye on improving quality. I am also, so I guess I'm speaking today as a strategic advisor for VMware in a session that's kindly sponsored by VMware. So that's a little bit about me. I want to focus on some of what we've done and have some time for kind of Q&As. So Innov8 were founded by 3 NHS leaders, myself and 2 colleagues. Ian Smith, for those of you who don't know, is an ex-deputy IT director from a large teaching trust. We are different and proud to be really different. So there are easier sectors to sell into, banking, finance, etc. But there is nowhere where technology leveraged in the right way can make the kind of difference that it can in healthcare. And having spent 5 years running an NHS trust in a really challenged NHS economy, I could see firsthand, I guess, both the pain and the frustration of not being able to truly transform for lack of investment in technology and lack of investment in the right kind of technology, but also, on the other hand, with North Nottinghamshire Health Informatics Service and looking further afield to other trusts where informatics services are really good, like Nottingham University Hospitals. Some of the transformation that can happen when technology is deployed and selected and used really well. So together with NHS organisations, Innov8 and VMware are working on a product called Mobile Medical Workspace. And we're looking to try and help, fundamentally, clinicians to deliver improved quality. And by so doing, to improve efficiency. So today's session is to share with you some of the successes of that work and some of the pains and some of the difficulties, and then to take some questions and answers. Before we do, I just want to engage you a little. So I'm really proud to have worked in healthcare for 5 years. I once saw a thing in Monitor's London offices where it showed an NHS chair at the beginning of their kind of chairmanship or steerage, if you like, full head of hair, bloke obviously, kind of 55, you know, but full head of hair. And then the next picture was same bloke, 2 years on, looked 60, half head of hair. 2 years on, completely no hair and looked kind of 70. And when I first started leading Sherwood Forest, I used to look at that picture and laugh. And I will never forget the last time I went down to Monitor, I didn't laugh anymore. So, you know, that was like looking whilst I'm not a bloke in my early 50s. I feel like I'm in my early 50s now. And the hair went grey, and I had lots and lots and lots of sleepless nights. And I guess, but I've never done anything that's made me so proud and so fulfilled. Probably poorest, but really actually it's great. And I think none of you would be here if you weren't proud to work in or with, as a vendor, the health service. So, and in fact, Ipsos Mori, my friend Ben Page, chairman of Ipsos Mori, tell me that 45% of Britons say the NHS is the one thing that makes them proud to be British. More than Team GB, more than the royal family, maybe not these days, surprisingly more than the BBC, that's probably self-evident. But actually, and the budget this year, £109 billion, serving 56 million patients. And I don't need to tell you that, you know, the age of those patients is increasing. Lots of comorbidities, lots of real fundamental issues. So the challenge for NHS boards and commissioners, for IT service providers, and for those of us who are vendors in the room as well, to try and embrace, is not just about how to do more with less, but how to do it very differently. This is about sandbox innovation. I asked a group of 80 chairs whether or not they expected the NHS to get better or worse over the next few years. What do you think they said? How many of you think they said better?
Half of them.
Half of them. We NHS chairs are a grumpy bunch of sods. 85% believed that their organisations and the organisations round them would fail to meet the challenges ahead, primarily the quality challenge. So lots of people are really concerned around mid-staffs and how do they improve quality. But by far and away, the biggest issue is the so-called 30 billion gap. And I think, I don't know about you guys, but it doesn't matter what you read, it gets bigger and bigger and bigger and bigger, doesn't it? Every time you read it. It's Nicholson's 20 billion, then it's 30 billion to 2021. And, you know, I guess by the time I really am in my 50s, it'll be a three-figure number. Where will those gaps and those savings come from, do we think currently? So I read some work that Monitor and the NHS Commissioning Board had done just last week about where they expected business as usual savings to come from. So current efficiencies, doing more with less, how much can we generate? How many of you in the room are from primary care? Anybody? No? Okay. Primary care have estimated kind of 1.2 to 2.5 billion pounds worth of savings towards that from doing business as usual. Anybody from an acute trust? Okay, bad luck, worse pain, unsurprisingly. 4.7 billion is the target from Monitor by doing all of the things that you're currently doing around SIP and to help commissioners meet their QIP targets, etc. So across 195 trusts. So by my reckoning, that's still about year-on-year SIPs of about 5.6, 5.7%. How many of you from community care or community care organisations? Okay. So still, despite all of the rhetoric about integrated care, about moving care into the community, still the DH and the Commissioning Board and Monitor are saying 1.8 billion savings. So I guess I've got a financial banking background, so, you know, I did know more. I've got my calculator out. And I wonder, where's the other 21 billion coming from? The other 21 billion has to come from radically different innovation. And I guess for those of you who are IT directors in the room, and if Eddie Otto was here, I'd apologise to him for what I'm about to say next. You know, I've sat on the other end of a board table so often and red-penned ICT business cases and asked those difficult questions about demonstrate the return on investment. What's revenue? What's capital? When am I going to see the SIPs? Only this year's SIPs can. Actually, I guess I'm on the other side of the fence now. But actually, this is about using the budget to keep the lights on, to do the XP migrations, to do the stuff that you need to do every day, being more efficient about that in order to invest more in the transformational projects, the projects that truly will make a difference. Uppermost in board members' minds, so my top tip for how to get a business case approved, talk about all of those things. So there's 9 domains: regulation, efficiency, transformation, particularly around care pathways and integration. Culture. So increasingly IT services are getting involved in the kind of social cost, social media, helping the trust, I guess, win friends and influence people without getting into the friends and family test and all of those good and great things. So at Innov8, we get those challenges, I guess is what I'm trying to say to you. Your challenges are our challenges. And trying to think through how together we deliver detailed and really actionable transformation from IT. I'm focusing relentlessly on adding genuine value. I'm going to apologise to other vendors in the room. One of my biggest frustrations up to February, and still I don't think we're doing it as well as I would want to, is about how as a vendor you add value to the challenges that the guys in front of you are facing. So not just worrying about when's your tender coming out, what lots are going on, what's the timetable, but actually what are the things that keep them awake at night and how do we really add value? I think we've lost a bit of that and we need to get back to it. We need to change the relationship between IT vendors and their IT deliverers on the ground, and between health informatics services and the boards that they're delivering for. IT needs to be about transformation. We need to develop different relationships. So a bit about mobile workspace and what we did. Probably won't expect. So this is supposed to be an anonymised version, but there are a number of examples. So 320 million PFI hospital across 3 sites. So a large district general hospital, deprived population, small district general hospital with an MIU second site, and an increasingly large community facility, serving a population of about 340,000 people, 30,000 inpatients every year, massive pressures through A&E. So this is a trust who have hit their 4-hour waits quarter on quarter for the last 3 years, but whilst I'm proud that they have, how, I do not know. By working harder and harder and harder, and by clinicians doing things during lunch, by the IT staff working overtime, by everybody doing more with less. The health informatics service concerned serving 10 existing NHS customers and really beginning to think about how they commercialise, how they pull together a commercial offering, thinking about how they deliver infrastructure as a service, desktop as a service, how they exploit cloud, how they even begin to have a conversation about cloud with their boards. So I was talking to one board the other day, and a couple of non-execs who I happen to think are not your average, more forward-thinking, more, you know, and one of them said to me, so see this cloud thing? Who invented it? You know, and I think, no, stop, we have to begin again. So, 10 million budget. Mobile medical workspace provides secure, single point of access to all clinical applications. We believe that it's faster, cheaper, more scalable, better VDI for healthcare. And we've spent the last 8 months working with healthcare organisations and clinicians on the front line, including acute clinicians and ED clinicians, to make sure it does just that. So it delivers the applications they need in the time that they need, that it gives them access anywhere on any device, irrespective of their location. So on call, whether remotely or over at the community hospital site. We've been very specific about this works on any device, although it drives me nuts because I'd like to get away from the iPad conversation with clinicians. You know, don't want particularly now that we've got iPad mini Airs, so it'll be even worse. But on any device. The initial project aims that we were given in terms of, so the NHS tender was about installing new appliance hardware onto 6 new customer sites, 6 customer sites for the health informatics service. Remediating and replacing hypervisor. I'm not going to read this because I'll make a fool of myself in terms of not getting the tech, but it was a list about single platform, 125 users per appliance. I had to learn a lot about IOPS, so the guys were talking to me about the number of IOPS required, and Matt's laughing, the number of IOPS required, etc. DR and disaster recovery, providing all components pre-configured. The issue for the health informatics service concerned were that I've seen more VDI pilots than British Airways have. Lots of POCs, struggling to get off the ground, struggling to get scale. They wanted something that worked out of the box. In truth, when we deployed it in April, May, it didn't quite work out of the box. It still needed a lot of that work with clinicians to make sure it was perfect. It now does. It still needs a lot of work. But it saves the health informatics service doing the knitting and the cabling and the wiring and making sure the switches work and making sure all of those kind of things work, taking other people's components and knitting them together. So this is an out-of-the-box, scalable appliance. But that wasn't the project aim. Those are the technical outputs, not the change required. They're not the things that would make a difference to the clinicians. So we did some activity follows, and for those of you in health informatics services, I've spoken to a couple recently and I've said to them, have you been and talked to the clinicians? I guess generally speaking there are some rule of thirds, isn't it? A third of them said not on your life. They'll ask us to do stuff. A third of them said, which is a bit horrifying really, a third of them said, yeah, I've spoken to them, but they, you know, they don't get it. They don't know what's the best technology. They want to choose the tin, you know, so they don't know what they want. We need to select the tin. They need to talk about what they want. And a third of them have been and started to do some of the activity follows, worked through and mapped out what they think they need to deliver, and that was all 12 months ago. And now they're saying, we know what we need to do, but we're still no further forward. We're keeping the lights on. We're doing a PAS replacement. We're thinking about Windows XP migration and so on and so forth. What are the things that keep you guys awake at night? So we did lots of activity follows, and we saw, none of this will be a surprise, massive delays for ED clinicians in accessing discharge information. Clinical hours lost, simply logging in and out of systems. We walked into one A&E department where the clinician said, and I love him for it, sad as it was, here are all my notes of how long it's taken me this week and how much time I've wasted logging in and out of systems. There's all the times I've gone to a machine on a ward and I couldn't log in because somebody smart cards left logged in, you know, and maybe they hadn't learned that CQC trick of cutting the end off, and so the CQC couldn't see it. So, yeah. And most places have, I think, now. So clinical systems logging in and out, loads of IG issues, and that's not a joke. I have been on those wards where you're all nodding, that's scary, okay? So clinicians not knowing when test results were through, and in particular in any A&E systems, not knowing whether patients were discharged or admitted. Scary, really, really scary. Cramped, congested wards, and I know how much time as an NHS chair I spent saying, what do you mean we've had 13 breaches overnight? What do you mean we're going to fail the 4-hour target? I don't think I realised at that point just the role technology could play in improving that whole process. And this is not just about efficiency. So I spent some time with an A&E consultant recently, and sorry, we're an IT organisation and this always sticks. But that's what I saw most of the day. And do you know what was said to me afterwards? You know, the only reason I didn't get that was because I was one of those, IT guys call it power users, so I must have had the most technically ineloquent person in the trust, but I probably had the best PC, didn't I? So, you know, actually that's what they were looking at, day in, day out, from ward to ward. So mobile medical workspace, how did it change those things? I'm not going to do a big sell. For those of you who want more technical information, we're on stand G11. Please come and have a look at the demo. We'd be delighted to talk to you. But essentially, this is about VDI like everybody imagines it should be. So it's about user authorization, about secure two-factor authentication. So this is one of the few systems that gives spine session persistence, so access to NHS spine applications, delivered with VMware, in partnership with VMware. So IDEM is just running View 5.3 under Horizon Mirage. So lots of other advantages, particularly around XP migrations and on platform changes and all of those kind of things. But access to secure Windows applications, access to PAS to EPR and to medical applications. So again, some massive advantages stepping forward, helping Health Informatics Service think about commercialization and catalogue of services and application management, those kinds of things. So full session persistence, VDI infrastructure, a secure workspace, delivered through single support contacts covering all of the component parts. And that was really key for our health informatics clients. They don't want to have to knit the bits together. They don't want to have to worry about how they get support for all of the parts. You guys don't care whether or not the issue is an AppSense issue or a VMware issue or an issue with the Wise clients or an issue with... You want to know that it's fixed and it's secure and it's supported in a single session. What's in Mobile Medical Workspace? Again, no real surprises. So data storage, application virtualization, user virtualization, SAN. So combined compute storage appliance-based design, has SSO and secure NHS smart card access. That won't be affected. We've been talking very closely with the commissioning board about Spine 2 and the changes coming up. We don't expect that to make any changes, and we're working through that. So really simple, scalable, enterprise-grade VDI architecture. Each one of our appliances, and you can see the appliance on the stand, supports at the moment about 125 users. So when I said I've seen more POCs and pilots than British Airways, actually where we've had real success so far, and I really genuinely mean this, we haven't done a POC that hasn't gone to procurement, where the users haven't loved it. We haven't gone to procurement where somebody hasn't either then scaled up or isn't currently talking to us about scaling up. And I guess the bottom line is, this is cheaper and faster. but it allows people to do it in a scalable way. So you can put an ED department on VDI, and then you can scale up. Process improvement, so information accessible on any device in any department. Full desktop persistence, exactly as it was left on a device. So one of the challenges that we were given by one of the T&O consultants that we were talking to was, do you know what, I'm fed up. I'm in A&E, I go up toward 33, I'm clerking patient, I'm looking at my patient records, I get an urgent call to go, you know, whatever, query, somebody in A&E. I want to be able to get the PACS image up on my iPad while I walk back down to A&E, to be having a look at it, to get into A&E and move the same session to my PC in A&E or to any other endpoint device. That's exactly what this does. We also deal with some of the IG governance issues, so I won't bore you with Improvata, fade to lock and single and secure walkaway and those kind of things, but those kind of things are quite clearly helpful. So full session transfer to mobiles, and all that's needed is to access is smart card and 4-digit PIN. Somebody asked us on the stand yesterday, so actually I'm an A&E consultant, and I'm going to, I might have an A&E session at our main site and then go over to our community site, and then I'm going home, but I'm on call, or I'm third on call. What happens to my session? Well, actually, the answer is you have 12 hours of smart card access remotely from home at the point of your last session, and that can be extended. So this gives access to working differently from different locations and in different places. All deployed in a single appliance-based solution, fully accredited by VMware. How many of you are current VMware users or customers, or I exclude those vendors in the room? Okay. So clinical staff impact. The so what? Why are we here? The bit that really excites me, I guess. This is an AD department. 83 minutes saved per consultant per day. 20 seconds cold start, log in the morning, approximately, and 4 to 5 second login when moving sessions. It is that quick. That's what's really impressing people as they're coming to the stand. Makes a massive difference. So no more blue circles, I hope, hopefully. 6 consultants in an average DGH A&E department, and currently it's an A&E department that's had 2 vacancies for 2.5 years, and they're not on their own. Lots of A&E departments, lots of clinical vacancies. So in total every day, more than 8 hours saved. What's this not about? So, the finance director, surprise, any finance directors in the room before I offend somebody? No. So the finance director said, only 1 vacancy, no more 2 vacancies, great, fantastic, productivity savings. The clinician said, unsurprisingly and rightly, no. This is about allowing us to see more patients through A&E, about allowing us to improve quality, and giving them the headroom to get, not just to meet the targets, but to deal with the things that matter to them. So the pain management in particular, you know. When I talk to A&E consultants and particularly senior nursing staff as well in A&Es, and say, what's the one thing that matters to you? I might be worried about 4-hour waits. What are you worried about? It's about pain management. It's about triaging patients quickly. It's about making sure, apart from the bitching and moaning about primary care 24 and all of those kinds of things, it's about those kind of things. So this has enabled them to do that. So there's 100K cost saving in an average 6-man A&E department. That's quite a small A&E department. There's no working through lunch to review the results. That's made a massive difference to the morale in terms of the department. No working at night reviewing emails, better access, shorter ward round, and importantly for patients, earlier decisions. So no more going around not having access because the nurse has left a smart card in and cut the end off, and you know, and building up a list of actions that you mean to get round to at the end of the ward round, but it doesn't actually happen until you finish your shift or you're sitting in the Costa in the foyer at lunchtime. More time with junior doctors, more training and more education, and I guess, you know, improved recruitment and retention. So, and I see no reason why that shouldn't be replicated across other departments. And you can work out for ourselves and for those other vendors in the room, you know, a lot of these benefits are around VDI, but it's about demonstrating the return on investment. And it's about the clinicians saying, this paid for itself they can see that this will pay for itself over an 18-month period, both in financial savings, but they can see the quality impact. So actually, if I go back, and I'm going to take you back to the slide that said this was about remediating hypervisor, and it was about 125 users per appliance. Actually, it wasn't. Yes, it's done those things. But this is about taking in a health economy that spends 252 million a year on acute care and 420 million pounds on primary care, and working out how do we contribute to that 21 billion gap in terms of that efficiency challenge. So for us, it was about facilitating closer integration of health and social care. So we're using this now to say, how can we support comprehensive geriatric assessment? Yeah, so my clinical bit will be boring the IT guys amongst you, but actually help your trusts to do that and to think about readmission penalties and those kind of things, and you'll demonstrate the return on investment on your IT. So enabling health and social care professionals to work together as MDT teams. How many of you IT guys in the room have started to think about how you get your hands on the integration money for next year? 3 billion. Anybody an IT person that hasn't started thinking about that? Come talk to me, I'll tell you how. It's really, really important, and it's not difficult. It's about doing these things and about getting them up front. And we were talking to the NHS Commissioning Board about this exact issue last week, about how do we get more investment in IT, and not just in acute care. Actually, for primary care, there's nowhere near enough investment. It makes me furious to see, and I apologise to those of you from acutes, it makes me furious to see the lack of primary care investment, and that, say, for hospitals, and the nurse tech fund is being focused around acute care and community care. It needs to be invested in primary care as well, and we all need to be working across those systems. So it's about reducing costs and maximising value, improving access to clinical information, and supporting the delivery of health and social care without boundaries. I'm going to say all of those nice things, aren't I? In terms of the return on investment and all of that. Some feedback from clinicians. So an acute medical consultant said, you've no idea what you've delivered. This changes everything for us. This allows them to sit and rethink about how we do things. If we can remove the pain points and the barriers, how do we redesign the way that we work? We're not there yet. We're only just beginning to support that process, and we've much, much, much more to do. But to be able to know that actually this removes some of those barriers is a great, great starting place. Head of IT said, without changing a thing, I've ticked some of those boxes. Reduced login times, single sign-on, done all of those things. Now how I'm going to do my XP migration now, I can do it on platform. I can probably save about 200k there to reinvest in doing things differently. So tap and go login, spine, session, transference in terms of those kind of things. And the IG teams are happy. That's all really great. The one that really made a difference to me was an A&E department consultant who is no technology fan, who used to come to me and say, I'm fed up. If somebody gives me one more digital pen and one more piece of tin and tells me that it's going to help me to do my job, I'm going to scream, I'm going to chuck it all in the bin. And same guy that used to sit in Costa Coffee with his big white pile of test results and go through them on paper still, because that's the fastest, easiest way for him to work, said, love it, love it, love it. So that's where we are. That's a bit about mobile medical workspace and a little bit about us. Thank you very much. I'm more than happy to take any questions. I was looking to see if my colleagues would join me to answer technical questions. I will do my best. Thank you for your patience. I hope this has been useful. And for those of you exploring VDI, please, irrespective of who you do it with, do it. Begin the journey. It really will help us to move towards really leveraging technology and transforming healthcare. Thank you very much.